So maybe we could start off really quick with a short introduction about yourself.
Sure, I can start. Hi, everyone. I'm Lena Nilsson. I'm the VP of Strategy and Operations at Analytic. It's a deep learning startup that helps doctors make better medical decisions.
Hi, my name is Julie Papanek. I'm an investor at Canaan Partners. We're a tech and healthcare investment fund. I lead investments in drug discovery and development and in digital health.
Hi, I'm Chris Hogue. I'm Chief Operating Officer of Propeller Health. We make small sensors that go onto medication inhalers and turn them into connected smart devices for people with asthma and COPD.
Rick Altinger, I'm the CEO of Gluco, and Gluco helps clinicians and patients make faster and better data-driven decisions associated with their diabetes to drive better outcomes at lower cost.
Great, thank you very much. So the panel and I exchanged a number of questions before today's discussion, and one of the things that came about was how entirely broad the subject of telemedicine and patient engagement is. And I wanted to ask maybe anyone who wanted to respond why this is such an exciting field for your company.
Sure, I'll start. I bifurcate the industry into those companies and solutions that are focused on wellness-oriented initiatives versus those that are more chronic disease-oriented. And today, I saw the latest stats over the weekend, 86% of our healthcare spend is in a limited set of chronic diseases. Gluco's in diabetes, Chris is in the pulmonary area. These are two of the bigger ones. And we're finally to the point where we have the right level of infrastructure and connectivity and the right level of incentives, both at the government level and at the individual health system level, to really want to engage patients in their chronic diseases so that we can have a big impact.
Yeah, similarly, I'm a data geek at heart, and we're collecting data on people's medication use that has never really existed before, and you start to see things around whether they're adherent or, but more importantly, their symptoms when they're using the rescue inhaler. And you can start to see these patterns and collect data in between doctor's visits. It's really valuable. And now we put it to work and we can start to see patients doing better for themselves and learning about their disease, and doctors and mainly care coordinators being more efficient. And it's very exciting to see it put to work. And as Rick said, it's really people are really starting to see the value and starting to be able to leverage it and use it for a great use.
For Analytic, we look at,
Go ahead, no,
you're
please.
turning this way. So, for Analytic, we are looking at telemedicine also as a tool that helps physicians in the office. So the immediate beneficiary isn't just the patient, but it's that patient-doctor relationship. And it's really a way to bring, in a virtual sense, hundreds of specialists and millions of prior cases to the hands of the physician that's currently working with the patient. And that's through this new technology called deep learning.
Great. And so one thing that seems to come up a lot is for the companies that ask the patients to adopt a service or the app directly, how do you get patients to do that given the amount of, or the very low engagement rates that you see reported in the industry? And if you're going direct to the employer, what's the pitch to the employer?
So I can start on the patient side. I think this is probably one of the bigger opportunities out there right now, especially around digital health, is how do you enroll patients onto a digital program that's going to help them. And the traditional players in the industry aren't super good at direct-to-consumer marketing and brand. And so we focus a lot on being very consumer-focused, very user-focused in our branding, and then developing direct-to-consumer marketing efforts to be able to go out and acquire them so that we can just take in a list from an employer or a payer or a health plan and do that work on our own to make it very frictionless for them. If we have to rely on the customer to help us enroll, it really adds a lot of friction. And so getting good at that is a tremendous value, I think, in the industry today.
Yeah, another key that we're finding, so by the way, Propeller Health, I think, is one of the grandfathers of the industry under the old Asmopolis name. And so a lot of us have followed suit there and done similar programs to that. We're also seeing two other dynamics that I would add to that. One is incentives by either employers or payers. So we're involved in a program right now where the average co-payment for employees with diabetes at this employer is about $550. And the employer is saying, if you participate in this diabetes disease management program, I will waive your pharmacy copays. So the pharmacy spend is obviously going up, but they have proof that shows that if you comply with the program, my overall spend, the number of emergency room visits, the number of complications goes down, and so there's a clear return on investment. So a little bit of incentive goes a long way. And then the other thing is that trusted relationship that exists. So we're in use by a few thousand endocrinology professionals and clinicians and such at this point. And when you go into that office for your checkup that you should be doing every 3 months, but in reality you do it every 7 or 8 months, building on that relationship, so learning about the technology from that trusted Dr. Welby type character, and knowing that they are monitoring you is key, we've found, to getting people to engage and to drive the behavior change that ultimately is going to result in better outcomes.
So in the case where you're covered by insurance or the employer will kick in some amount to help coverage, that makes sense. But in the situation where the patients have to pay out of pocket, what percentage of patients would you figure would pay out of pocket for your services, and how much?
Yeah, so we offer a direct-to-consumer service today, and we have patients that use it and love it, and we charge $60 a year for that. But here in the US, getting people with chronic diseases to pay a significant amount is not a reality. We actually pulled the direct-to-consumer service 2 years ago, and there was such uproar by some people in a small zealot community that we started making it available again. But I really don't encourage, here in the US, anyone to try and build a big business direct-to-consumer in the chronic disease management arena.
And Julie, what do you think about that? Any investment opportunities for direct-to-consumer plays?
I'm really biased. I mean, we funded the B2B switch for Gluco, are thrilled with it. So I would actually say that if you're trying to get consumers to pay, at least my personal rubric is you have to look at them as a consumer and not necessarily as a patient. And the places that you see them pay are related to identity purchases, things that have to do with who you are as an individual. Maybe you're someone who cares a lot about a gluten allergy. Maybe you're someone who really cares about a yoga community. Maybe you're someone who is managing a parent remotely and you're dealing with your own stress. Or where we see the majority of the utilization in telemedicine today is just fundamentally about convenience. I mean, like, I'm willing to pay $40 out of pocket because I'm willing to pay for Teladoc to talk to a doctor now, most likely because I just need a prescription and I know what my problem is. So the issue is you don't want to have to wait on hold with your practice. And the issue that I am dealing with as a consumer is patience, convenience, access to a doctor when I want it. I see that very differently than chronic disease management, where someone else who has cost on the line, big dollars on the line, are trying to change my behavior versus behavior that as a general consumer, I'm reaching out to try and buy because I think it's a great product. So that's part of the reason why I think Rick's point about having a doctor recommend their product and having a third party pay for it makes so much sense for that specific version of telemedicine.
And any pitches that you've come across or any portfolio companies that you have that are successful in having the patient drive doctor adoption?
No. No.
Yeah.
And I'm sure that there are exceptions to that rule. And, I'd actually say if you do have exceptions to that rule, please come to the mic. Because I would actually say that that's really important for us all to learn from those crucial examples. I don't necessarily think that patients are going to draw in enterprise solutions in the same way that you've seen with Dropbox and Box with employers. I think it's a pretty different hierarchical relationship and some really different asymmetrical sets of information. So I haven't seen that as much. But I would love to learn about companies that have done that. And
I can point to some, including one I worked for, Healthy on WebMD, that spent probably $100 million trying to drive patients to fill out health risk assessments and filling them out with claims data for them, and then having them bring them into doctors to try and get doctors. Yeah, it didn't work.
For Inlytic, we're not a direct-to-consumer product, but work with hospitals and doctors. We still have patients contacting hospitals in Australia, our first market. I think in part because the product, radiology products, are products used often with patients who might suspect they have a cancer or serious illness, and this is the first entry point into treatment. So there's a lot of pressure and anxiety around treatment options. So
Yeah.
we'll see.
In other countries, so we've had some patients, small number, literally measured on my fingers and toes in India, that get our product, pay direct to consumer, and then we've had some physicians contact us and say, yeah, a patient brought this, we think it's really cool. So I think in other countries like India, there's a clear direct to consumer opportunity.
It's not in this one.
Not in this
The
one.
road is paved with dead digital health companies that try to get people to pay for things that they're used to other people paying for.
So another, to more novice investors like myself in the healthcare space, another kind of question I have is maybe for Lena. When you look at technology that builds itself as an AI diagnostic tool with a networking component to it, to us, to many web investors, we just look at, the first question that comes to mind is, to what degree is this really new science, new diagnosis, and how much is it just essentially old science but with a Wi-Fi router?
Sure, so the technology, it's often called AI, or we call deep learning. It's the specific type of AI. Basically, rather than coding in specific rules for computers to, for example, make a diagnostic based on a medical image, you show the computer hundreds of thousands or even millions of images, and it learns the patterns of specific diseases or specific abnormalities. This is something that, in the case of images, has had human-level performance since 2012. It's used in a wide range of industries, like financial analytics, within a lot of internet applications. You do Google search on, or Baidu search, for example, on cats. That uses deep learning in the background. Skype does as well. Basically, all the big tech companies. So it's an emerging technology, but it's not new, and it's being commercially implemented in a lot of areas, just not yet in medicine.
Got it.
On that, I think what is new, though, is the access to data.
Yes.
The models aren't changing, it's the data that's changing. And so you have companies like ours where we're collecting vast amounts of data that never really existed before, and then you can apply different models to it and see, we can see and predict asthma risk for an individual using wind and pollen counts and air quality. And it's just because we were early and are able to collect all this data. So I think that's the value that's coming today.
Yeah, I agree. That's one of the things that drives excitement. And we saw it, one of our clinical programs that we produced some results on last year was a manual process where people were using our product, clinicians are using our product, they can see what's going on and they'd coach. But we saw the single biggest cohort of what they were coaching on was, oh, this patient is on an expensive DPP-4 or other drug, and yet we're not reaching glycemic control. And so the endocrinologist, once they had access to the data, the top-line endocrinologists could say very quickly, we need to change their care plan. We don't need them to come into the office. And you could make those decisions quickly based on having actionable information when they want it. The other thing that we've learned, and you guys have been doing it as well, is you don't push messages to clinicians. Clinicians come when they want it. They don't want their text messages. They don't want their beepers to go off, and many of them still have beepers. They want it to be an on-demand access to the right information.
So maybe maybe Chris, what is the ROI pitch that you have to the enterprise that, look, the clinicians will use it?
No, it's based on costs that people, for us, it's people with uncontrolled asthma or frequent exacerbations in COPD are very expensive, and they're much more expensive than people who have their disease under control. And so since the company's beginning, have been doing clinical research and publishing it, and right now we're doing a big cost study. You have to bring real data and real epidemiology data, real data of your impact to these enterprises. You have to make a pretty sophisticated ROI sell. But when you do, then it's very compelling to them. But there's a certain level of evidence that they're expecting to see now, or they always have. I mean, pharma companies have been bringing a lot of data for many years, and they expect similar. And so you have to bring the goods, I think.
And for budding entrepreneurs in this space, how do you, what advice would you give them as to how to bridge the gap when raising money and trying to show statistics or data or usage to larger companies?
Start super early on day one, have a data collection, data evidence plan, and get clients who are willing to take a bet on something new, even if you're giving it to them for free just to build the evidence. But you have to do it in a rigorous enough way that when you get to the end, the data you've collected are good and useful.
Yeah, the advice someone gave me is Petri dish. Start with a Petri dish where you're going to have easy access to, can be a very small N of patients, right? We started, our first group was 10 patients at Scripps Medical Center in San Diego, and prove out that it helps the clinician and that you can drive better outcomes, that lower costs. And then expand from there, but really nail the data first, as Chris said, in a small population.
And maybe, if you don't mind me adding to that, I think really importantly is early on it's so refreshing when you see a team that comes in and they say, the purchaser of my product cares about this metric. And this is the pilot that I am going to fund in order to get that validation. So essentially, what is the indicator that shows that you're going to save costs in some way, shape, or form? And it might be that you need to do a 2-year trial to show hospital readmissions, but is there something in the near term that is what, if you work in drug development, you think of it as an early endpoint, something that doesn't take 5 years to pan out, but everyone in the industry in that sector knows is really clinically relevant, and that relevance clinically translates to dollars. So I'll give an example for A1C associated with diabetes, keeping that in control. There's plenty of studies that have already proven out what that band of control means in terms of savings. I think an example that all of us in this community are really familiar with is Omada. So Omada leveraged other data that is out there that if you lose X% of body weight, that saves Y dollars in a 1, 2, 3, 4, 5-year time frame. So I'm always looking for companies that have a really clear understanding of what data they need to generate and how they can generate it. Is it with CVS and Caremark because you need claims from a pharmacy product? Is it medical benefits in which you really need to get into an HMO and I want to see who you can work with to get access to that data? Or is it something completely different? Is it actually related to employers and retention and engagement? So who are you trying to sell to and what do they actually care about? It's really quite nuanced. And I want to give a shout out to Jordan from Kaiser because they have done an incredible job as a partner for so many companies in this ecosystem to create the right type of trial where we get clinical outcomes, cost savings, pharmaceutical utilization, everything you can think of that you need to be able to go to a plan and negotiate. So I just want to say thank you, Jordan. We are very grateful for the work that Kaiser has done for this entire sector.
I could add too for data that it's also an opportunity for medical community buy-ins, so it's both investment and the medical community, and a big part of that for Analytic at least has been through peer review, so getting the quality of data high enough that medical reviewers will say, yes, this is indeed having the impacts both on accuracy, on the medical outcomes, but also on factors such as cost or time needed for an intervention.
And I think it's a good segue to the topic we all love, which is insurance. How do you see the prospects for getting insurance coverage changing in our field?
I can go. I mean, the biggest shift is of course, to value-based contracts. And so we focus almost exclusively on people in value-based contracts. The concept of waiting and trying to get a fee-for-service billable code or working with CMS to get that is not really palatable on these timelines. And so I think if you're looking at where the market's going, more time spent generating evidence on cost and clinical improvements and efficiency improvements to people who are at risk and systems who are at risk rather than trying to go the fee-for-service route, at least in our business.
Yeah, I would agree. And the costs of care have been going up dramatically. One of Canaan's other portfolio companies, Truveris, helps self-insured employers see where their costs are growing, particularly on the pharmacy side. So I have seen in the last really 2 to 3 years, the health plans, whether it's the traditional Blues or Aetna and United, saying my self-insured employers, which is largely their largest book of business, they're seeing their costs for the chronic disease patients go up. We have to do something, and so they're much more open to innovative programs, and the value-based care structure allows them to engage, and they're engaging with the care teams much more closely with tools like Gluco that can help those providers more closely monitor patients and drive better outcomes at lower costs.
Great. So it seems like lower costs, better outcomes, but we'll still need you to pay for it.
They're paying for it now, right? They're paying today for the emergency room visits associated if your asthma goes out of control. So it's a matter of shifting those dollars towards preventative as opposed to reactive.
Great. I think we have maybe a couple of minutes for questions for the audience. I think there are a couple of mics. And if there are none, I'll make something up. Great.
Oh, there's one. I see one.
We do.
Hi, McPherson from Berkeley. I'm curious, I love hearing what Julie said about Kaiser's doing this great work to support entrepreneurs and firms trying to build this evidence base, because it feels like a lot of times the pilots are poorly constructed, the endpoints are poorly defined, and a lot of that is just, there's no expertise or technical assistance available for companies as they start out. I'm wondering, beyond Kaiser, where else are panelists, Julie, others, seeing this kind of support? Because I think if we're demanding evidence, and we have every right to do so, who's supporting these enterprises with their ideas, helping them build robust trials and pilots so that we can generate the right evidence? We don't go off track with these windows.
Yeah. So, by the way, nice to see you. And I'd love to hear your opinions of who, as on the, both on the payer and the provider side, who you've encountered that helped you design a trial well. So I think it really varies on the application for the telemedicine product or digital health product. I've been really impressed with some of the data that's come out of Intermountain and Geisinger. But these are also organizations that are fairly sophisticated in terms of the data scientists and clinical scientists who they have on staff who are used to designing clinical trials for other forms of interventions. So, broadly in healthcare, how do you design workflow that is cost effective, and how do you test that for your organization? If you think about it, those entities are so far ahead of the curve on that process improvement for themselves. Similarly, Caremark has an army of people that their entire job is to figure out if one tactic versus another tactic moves drug volume. I mean, they have an army. And so they are really good. So Express Scripts is really good at figuring out what moves drug volume as an indicator of change in outcomes and behavior. So I've been incredibly impressed. And a pilot with Express Scripts is like, 20,000 people or 200,000 people. That's a pilot. That is really different than when you're talking about a 20-person pilot. And so the statistics you can run on that sort of sample because of the installed base and the lives they touch is really dramatically different. So I'm excited to see organizations with access to hundreds of thousands of lives doing large-scale pilots to be able to give that sort of rigor that you're describing.
We find there's definitely two camps. There's sophisticated folks, so PBMs and Kaiser. We've worked in Dignity. We did a big study that we just published with Dignity. There was a randomized trial. And then there's groups that aren't, and we bring the expertise then. So we have people on our team, myself included, who we're worked in pharma and clinical research, and we have a research team, and we come in and help navigate what the protocol should be, what the endpoint should be, using our experience of what we've seen in the past. I mean, these are our data. We have the most experience with them, so we can really help kind of craft that study with them. So you have to partner with them to do it.
Yeah, we're not, 10 years ago, the majority of physicians worked in smaller organizations. I think it's 75% 10 years ago worked for groups that were 10 physicians or below. That is flipped. Now it's over 80% work in groups that are 50 physicians and above. And these bigger organizations all have, an innovation interest. And for me, for example, when I was recruited by the founders 3 years ago, I went and talked to some endocrinologists at Stanford, at Sutter Health, PAMF, at Scripps, and it's a real clear indicator. If they're not seeing the value proposition in it, then there's not a there. There's enough of these larger, innovative health systems now, and they want to do programs like this, so you can get a pretty good indication. And if you're having a hard time finding them, then perhaps your solution isn't solving a big enough or real issue.
So I hate to cut you off. This is a great conversation. Can you guys hear me through here? Thank you guys. Amazing panel. Thanks for Roman.